First, we use ultrasound to identify the renal collecting system, point it at the below of 12 rib. Then, the skin are infiltrated with local anesthetic using a spinal needle. As a radiographer, don't forget to warning the patient before inserted the needle. It will be a sharp stretch and a little bit of a sting. Using the 21 gauge introducer needle are advanced into the dilated pelvis. So just decompressing the system slightly before we add any contrast. This might minimize any chances of bacteria. Then we injected the contrast. As you can see, it's going free into the collecting system. Upon a successful puncture, a J-guard wire is inserted and a coil within a collecting system. Here how it will look like at the fluoroscopy. Then we can remove the 21 gauge introducer needle through the guard wire. Then introduce 6 French. The later assembly is advanced over the guard wire into the collecting system. Now we injected more contrast just to confirm position of renal pelvis. Now we put extra stiff guard wire, which will give us more support to dilate the tract. So just put an X French dilator just to start dilation of the tracts. Then use 10 French dilator. So for the drainage, a pigtail catheter with large holes along the inner surface of the pigtail is chosen, as these are less likely to obstruct once the system decompresses. For this size, we use 6 French. So once the tip of the catheters into the collecting system, we can unlock the metal stiffener and slide the catheter over the wire that will coil up within the renal pelvis. Now we can lock the pigtail catheter. Then it can fully decompress the system. Now we can just put the pump onto the end of the catheter. Lastly, we can attach a drainage bag to the external hub.
What is percutaneous nephrolydotomy? Based on what I have been explained in the previous slide, percutaneous nephrolydotomy or PCNL is a kidney stone operation to remove large or complex kidney stones. Before the procedure, the patient will receive an antibiotic either by mouth or through an IV. After that, the surgical team will place the patient very carefully into the prone position. Once the patient is asleep, the urologist will make a small, approximately 1 cm or smaller incision. There insert a protective sleeve sheath through the incision and into your kidney. A tube is placed through the incision into the kidney under X-ray guidance. After that, a small video camera nephroscope then inserted into the sheath to visualize the stone, break it up into smaller pieces and remove it. To help kidney and drain urine during healing process, the urologist may place a nephrostomy tube or a ureteral stent at the end of the procedure. A nephrostomy tube is a tube catheter placed in the kidney that connects to a drainage bag to collect urine outside of the body. However, ureteral stent is a small plastic tube that is placed in urinary tract to help control swelling and allow kidney to drain urine. The stent typically remains in the body for 4 to 14 days. Shortwave lithotripsy, or we call it as percutaneous lithotripsy, PCL, is a minimally invasive procedure used to remove kidney stone. The procedure started with X-ray or ultrasound to find the exact location of the stones. On this procedure, the patient will be on a supine position. Shock waves from outside the body are targeted at the kidney stones to break it into small pieces. After that, the fragmented kidney stones are usually passed through the urine. And then a ureteral stent may be inserted in the urinary tract after the procedure. Ureteral stent helps control swelling and allow the kidneys to drain urine. The ureteral stent remains in the body for 4 to 7 days and removed thereafter.
Patient supine in lithotomy position. Cystoscopy is inserted to locate the urethral orifice of the affected ureter by monitored fluoroscopy, and it is pushed till it reaches the 1/3 of the proximal ureter, or the highest point it can be reached. Then contrast media will be injected into ureter. 3 until 5 ml contrast media is inserted. Contrast media can identify collective system lesion or stone with fluoroscopy. This is antegrade procedure. Patient in prone positioning. Patient will be anesthetized first, then the kidney will be examined and located using ultrasound. Use 22 gauge Chiba needle injected directly into the renal collecting system. The needle is connected to the contrast loaded shrink, then contrast media introduced into renal collecting system. This will be removed and put sterile bandage on the site of insertion. Then spot image will be taken out after the contrast introduced into the renal collecting system.
Intravenous urography or IVU. Based on what I have been explaining to you, intravenous urography or IVU uses a contrast dye to visualize the urinary system, including the kidneys, ureters, and bladder. The contrast dye is injected intravenously, and X-ray images of the urine are taken at specific inverters in order to track its passage through the urinary system. The procedure started with set up the IV line at antecubital vein, apply swab, use tourniquet to ensure vessel visibility, and needle inserted at remove tourniquet. Needle from 19 gauge is chosen. Drain the contrast media into shrink. Place tape at the needle site to ensure it is maintained not moving, and hand vein of the antecubital fossa. Injection is chosen. There's 6 film sequences in this procedure. First, preliminary, immediate, 5 minutes, 15 minutes, release for 20 minutes, and post-micturition. So the procedures start with timing set up. Once contrast media administered, start the time. For the immediate film, 10 to 14 seconds after the injection, used to visualize the nephrogram or nephrotomogram, the renal area will be enhanced by contrast. Next, for the 5-minute film, evaluate the excretion both kidneys side. Compression is applied after the image taken after each 5 minutes. There will be no compression if the patient is after the abdominal surgery, renal trauma, abdominal mass, or if 5 minutes show distended calyxes. Next, for the 15-minute film, demonstrate the adequate pelvic calyceal system. Release compression if satisfactory. After that, for the release film, 20 minutes, show the whole urinary tract. Proceed for bladder empty if satisfactory achieved. And lastly, for the post-micturition film, used to visualize the bladder emptying and show as it returned to normal dilated tract condition. Voiding cystoretrogram, also known as micturating cystoretrography, is the study of the urinary bladder, urethra with the patient need to micturate to complete the examination. It is usually done for child and young baby. The procedure started with patient supine on the table. Next, insert the catheter with lubricating gel and place it at the tip. For child patient, make sure to hold the patient to avoid any movement. And drain excessive urine. Insert contrast media till bladder dilated. Images taken when the contrast media fill the bladder till any reflux noted. Spot film taken during micturating and any reflux is noted. The patient should micturate in left anterior oblique or right anterior oblique. If there is suspected of vesico-vaginal fistula, lateral image should also be taken.